Okay, let's get straight into it. Today isn't just a standard deep dive. Uh, this is essentially a war room session. We are tackling one of the absolute cornerstones of the MD anesthesiology curriculum.
It really is.
It's a topic that looks deceptively simple on the surface. Who goes to the ICU? But it's an absolute minefield in the actual exam.
It is indeed. And frankly, if you are a postgraduate student preparing for your exams, whether it's for Gujarat University or the National Board, this is your bread and butter. We are talking about criteria for ICU admission. And I'll be honest, most students fail this question not because they don't know the medicine, but because they don't know the structure.
Exactly. The trap is thinking, oh, I know who goes to the ICU. Sick people go to the ICU. But that answer gets you kicked out of Aviva, doesn't it?
It certainly does. The examiner doesn't want your intuition. They want a framework. They want to know that you understand the physiology, the ethics, and crucially, the resource management.
So our mission today.
Our mission is to convert a mountain of source material. We've got O's Intensive Care Manual, Miller's Anesthesia, ICU Protocols 2020, and Harrison's into a structured, Viva-ready answer.
So the goal is clear.
Yeah.
We need to synthesize all of this into something you can write in a long answer paper or, spit out confidently when an external examiner is just staring you down.
That's the one.
Let's set the stage then. Why does this specific topic matter so much for the exam?
Well, it appears everywhere. You might get a long answer question like, discuss the principles, indications, and models for ICU admission.
Okay, the classic long question.
Exactly. Or you might get a short note specifically on priority-based admission models.
Right.
And in the Viva, it's the classic curveball. Doctor, you have 1 bed left and 3 patients. Who do you refuse?
That is the nightmare scenario. You have the septic patient, the post-op patient, and the terminal cancer patient. How do you choose without looking like, a monster or an incompetent doctor?
Precisely. So to navigate that, we need definitions. We can't just say the place with the ventilators. That's not a postgraduate answer.
So we start with the fundamentals.
We have to. We need to look at O's Intensive Care Manual. It gives us a very precise definition that you should essentially memorize for your opening statement.
What is that definition? Let's get the wording exact for everyone taking notes.
Okay, so O's defines the ICU as a distinct organizational and geographic entity for clinical activity.
Okay.
Its purpose is to monitor and support threatened or failing vital functions in critically ill patients to improve outcome.
Threatened or failing vital functions.
Yeah.
That is a key distinction, right? It separates the people who are already crashing from the people who are just about to crash.
It is the crucial distinction, and it leads us directly into the principles of admission. We have to answer that fundamental question: who actually needs that bed?
And this brings us to the objectives of admission, I assume.
Yes. We aren't just warehousing patients. We are there to preserve life, reverse organ failure, and limit morbidity. It's an active process.
Right. So let's break down those principles. If I'm writing this answer or answering the examiner, what is the first pillar I need to establish?
The first, and honestly the most critical word for your exam paper is reversibility.
Reversibility.
It's the golden rule. Based on O's, admission is reserved for patients with a reasonable chance of meaningful functional recovery.
Okay, so meaningful functional recovery.
Yes. The ICU is not a place for custodial care of end-stage irreversible disease. If the pathology cannot be reversed, then, well, the ICU adds no value. It just prolongs the dying process.
That sounds harsh when you say it out loud, but it's the reality of resource allocation, isn't it?
It is the ethical principle of distributive justice. When demand exceeds supply, we have to triage. We cannot deploy limited, expensive resources where they won't fundamentally change the outcome.
Okay, so reversibility is pillar 1. What's next?
So after reversibility, the second pillar is differentiating monitoring versus support.
Break that down for me.
Support is for failing organs. I mean, someone needs a ventilator because they aren't breathing, or vasopressors because their blood pressure is gone. That's the obvious part.
Right.
Monitoring is for threatened organs. They aren't failing yet, but they might crash at any moment, and we need to be there to catch it instantly.
Can you give me a classic example of a monitoring admission? The kind of patient who looks deceptively stable.
Absolutely. A severe diabetic ketoacidosis, a DKA, who is breathing okay but has a pH of, say, 7.0, or a patient immediately after a major vascular aneurysm repair They look fine now.
But they're ticking time bomb.
Exactly. If that graft blows or the acidosis deepens, you have seconds to react, not minutes. You're paying for the one-to-one nursing vigilance, not just the machinery.
And I assume this all leads to the famous concept of the window of benefit.
You've got it. We often call this the too well versus too sick concept. This is the conceptual framework for your answer.
Too well versus too sick.
Yes. You exclude patients who are too well stable post-op patients who can be managed in a high dependency unit or on the ward. And you exclude those who are too sick, where death is imminent and unavoidable, making ICU care medically futile. The ideal ICU patient lives in that narrow strip right in the middle.
Okay, that's the philosophy. But exams love classifications. I see priority models mentioned in Miller and the Oxford Handbook. This seems like a very high-yield section for the written paper.
It is. If you get a question on admission criteria, do not write paragraphs of prose. Draw the priority table. The Society of Critical Care Medicine, the SCCM, guidelines break this down into 4 priorities. This is how you show the examiner you've read the standard texts.
Let's walk through them explicitly then. Priority 1.
Priority 1 are your critically ill, unstable patients who need intensive treatment that cannot be provided anywhere else. These are patients requiring, for example, mechanical ventilation or vasoactive drugs. There are no limits on the therapy they receive.
So these are the slam dunks, the no-brainers.
Yeah, correct. A patient in septic shock on noradrenaline or acute respiratory failure requiring intubation. There is no debate here. If you refuse a priority 1 patient, you are, well, you're negligent.
Okay. Clear enough. Priority 2.
Priority 2 requires intensive monitoring. They are currently, let's say, stable-ish, but they're at risk of immediate catastrophic decompensation. They don't need organ support yet.
But they might at any second.
Exactly. If they crash hard.
We mentioned DKA earlier. Does that fit here?
Yes, severe DKA fits perfectly here.
Wow.
Also, think of patients with chronic comorbidities who develop an acute severe illness, like an elderly patient with bad COPD who breaks a femur and needs close watching for respiratory failure. They are essentially pre-code blue patients.
Right. Now, priority 3, this is where it gets a bit gray, and I feel this is where the Viva questions usually focus.
It does. It absolutely does.
Yeah.
Priority 3 patients are critically ill and unstable, but, and this is the key phrase, they have a reduced likelihood of recovery due to underlying disease, or they may have limits on therapeutic interventions.
Limits? You mean like a do not intubate order, a DNAR?
Precisely. Let's take a patient with metastatic lung cancer who develops a nasty infection and goes into shock. We might agree to admit them for a trial of antibiotics and fluid resuscitation, maybe even some vasopressors.
Okay.
But we might agree beforehand with the family and the oncologist that we will not intubate and we will not do CPR if their heart stops.
Nope.
They get the bed, but their ceiling of care is lower than a priority 1 patient.
That's a crucial distinction. And in a bed crisis, priority 1 trumps priority 3.
Every single time. And explaining that logic is how you pass the Viva. You prioritize the patient with the unlimited potential for recovery over the patient with a capped or limited potential.
And finally, priority 4.
Priority 4 is the no benefit category. This actually has 2 subtypes, which is a good detail to mention.
Okay.
Priority 4A is the patient who is they're too stable, they're safe for the ward. Priority 4B is the patient who is too sick, irreversible damage, imminent death. Neither belongs in the ICU.
So if the examiner asks about a patient with a massive intracranial bleed, GCS of 3 fixed and dilated pupils.
Priority 4B. Admission is generally inappropriate. The only exception is if it is for organ donation, which is a very special category we will touch on later.
All right, we've covered the models and the philosophy. Now let's get into the clinical meat of it. The examiner asks, what are the specific criteria, doctor? We need to go system-wise here.
We have to.
This is the structure O's in Harrison's favor, and honestly, if you structure your long answer this way, you just make the examiner's life easy.
Always structure your long answer system-wise. It shows you are organized, you're methodical. Let's start with the respiratory system. This is often the primary driver for admission.
Of course. ABC, airway, breathing.
Exactly. Now, I'm looking at the 2020 ICU protocols source here. It gives us some hard numbers. Students love numbers.
Numbers are essential for the exam paper. You can't just say trouble breathing. You have to cite quantitative criteria.
So an acute respiratory rate, or RR, greater than 35 breaths per minute is a major trigger.
Why that number? Why 35?
It's physiology. Because above 35, the work of breathing becomes unsustainable. The respiratory muscles, your diaphragm, your intercostals, they will fatigue, and respiratory arrest will follow. It's almost inevitable.
Okay, so RR greater than 35. What about oxygenation?
SpO2 less than 90% despite supplemental oxygen, or a PaO2 less than 60 millimeters of mercury. These are classic definitions of acute respiratory failure. But don't just stop at the numbers. Look at the mechanics.
Mechanics.
Yes, look at the RSBI, the Rapid Shallow Breathing Index.
That's usually an extubation criterion, isn't it? We use it to decide if someone can come off the ventilator.
It works both ways. An RSBI greater than 105 indicates rapid, shallow breathing, which is a very inefficient pattern. It predicts fatigue and the likely need for ventilation. It's a great objective number to throw at an examiner to show you've read beyond the basic textbook.
And the clinical signs. The things you see from the end of the bed.
Marked use of accessory muscles. You can see their neck muscles straining. Abdominal paradox, that classic seesaw breathing pattern where the chest goes in and the abdomen goes out. These are signs of impending exhaustion.
In specific conditions.
Oh, yes. Status asthmaticus, for one. Severe pneumonia is another. If you're using the CURB-65 score for pneumonia, a score greater than 3 usually mandates ICU admission.
Okay, that's a very comprehensive look at respiratory. Moving to the cardiovascular system, Harrison's and Miller have a lot to say here.
The headline here is shock, but again, you have to define it for the examiner. We generally look for a systolic blood pressure less than 90 mmHg or a drop of more than 40 mmHg from the patient's known baseline.
The baseline is so important, especially in hypertensive patients.
Vitally important. A pressure of 110 might be fine for a young person, but it could represent profound shock in an elderly patient whose baseline is 180.
And it's not just the number, it's the support required, right?
Correct. The need for vasoactive drugs, vasopressors, like noradrenaline or inotropes like dobutamine, is an automatic ticket to the ICU. Wards cannot manage these infusions safely.
Why not? This is a good point for Aviva.
2 main reasons. First, the risk of tissue necrosis if the intravenous line infiltrates. These drugs are potent vasoconstrictors. Second, the need for continuous beat-to-beat monitoring. You need an arterial line to titrate these drugs safely. A ward that checks blood pressure every hour is just not safe enough.
What about arrhythmias?
Life-threatening arrhythmias, ventricular tachycardia, complete heart block requiring emergency pacing, or any arrhythmia that's causing hemodynamic instability. Also, complicated myocardial infarction.
Complicated how? What's the difference between a CCU patient and an ICU patient?
An uncomplicated MI goes to the CCU, the coronary care unit. But if the MI is complicated by cardiogenic shock, rupture of the ventricular septum, or a papillary muscle, or severe heart failure, they come to the general ICU.
Because they might need more than just cardiac support.
Exactly. They might need intubation, ventilation, or even mechanical circulatory support.
Got it. Let's move upstairs. Neurological system. O's and the Oxford Handbook are the guides here.
The magic number is 8. A Glasgow Coma Scale, a GCS of less than 8 usually implies the inability to protect the airway. GCS less than 8 intubate is a mantra, and that involves an ICU admission.
What about trends? I always feel like a GCS of 12 that becomes a 9 is much scarier than a stable GCS of 9.
That is a vital point. A rapid decline in GCS dropping more than 2 points over a short period is a major red flag. It suggests an expanding pathology like a bleed or cerebral edema. It's about the trajectory, not just the snapshot.
And seizures.
Status epilepticus. Specifically, status that is refractory to initial benzodiazepines. If you have to start a propofol or thiopentone infusion to stop the seizures, you have just bought an ICU bed. You cannot manage a propofol infusion on a general ward. Period.
And there's that specific slightly grim category you mentioned earlier from O's Chapter 90?
Yes, the brain-dead patient. This is a valid ICU admission for the very specific purpose of organ donor management.
So the goal isn't to save the patient.
The goal has shifted. We maintain somatic support, we keep the heart beating and the kidneys perfused to preserve the organs for transplantation. It's a distinct ethical and clinical category, and mentioning it usually gets you bonus points for thoroughness.
Moving on to the renal system.
No.
Chapter 47 and Bellomo's work are the big authorities here. It's not just kidney failure, is it?
No, absolutely not. Chronic renal failure patients go to the ward for their routine dialysis. We are talking about acute kidney injury, or AKI, with life-threatening complications. And again, you need to know the numbers for the exam.
Hit me with them. What are the triggers?
We usually talk about the indications for renal replacement therapy, or RRT, as the trigger for ICU admission. So oliguria less than 200 milliliters in 12 hours, or complete anuria, urea greater than 35 millimol, creatinine greater than 400 millim.
These are pretty severe numbers.
They are, and more importantly, the associated electrolyte disturbances.
Potassium.
Potassium is the killer. Hyperkalemia greater than 6.5 millimol L, or potassium that is rising rapidly, especially if there are ECG changes like peak T waves. Also, severe metabolic acidosis, a pH less than 7.1 that isn't responding to bicarbonate. These patients need dialysis acutely, which often means an ICU bed.
Let's talk about the big one. The one that crosses all systems, sepsis. The definitions have changed over the years. What should the student quote in the exam today?
Stick to the sepsis 3 definitions. You'll find these in Miller and all the recent guidelines. Sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection.
And how do we measure that organ dysfunction for the admission decision? It sounds a bit vague.
It's measured with the SOFA score. That's the sequential organ failure assessment. An acute change in the total SOFA score of 2 or more points from baseline is consistent with sepsis. But at the bedside, before you have all the labs back.
You don't have time to calculate a full SOFA score.
Exactly. Use the QSOFA, the quick SOFA.
That's the bedside screen.
Right. It's just 3 criteria. 1, altered mentation. 2, systolic blood pressure of 100 mmHg or less. 3, respiratory rate of 22 or higher.
And if a patient has 2 of those?
If a patient has 2 out of 3, that's an ICU alert. It's simple, it's fast, and it's highly predictive of poor outcomes. It tells you this patient is sick and needs escalation.
That covers the medical side brilliantly. But as anesthetists, a huge chunk of our work is postoperative admissions. Miller and the Oxford Handbook are very specific here. This is where the exam really tests your perioperative judgment.
This is a very high-yield area for any anesthesia exam. You can divide this into 2 broad categories: elective high-risk and unscheduled or emergency admissions.
Let's start with elective. I'm booking a patient for surgery. Who do I need to book a post-op ICU bed for in advance?
It depends on the interplay between the surgery and the patient. First, the surgery itself. There are certain major procedures that almost always require an ICU bed.
Like what?
Think cardiothoracic surgery, a Whipple's procedure, an esophagectomy, major liver resections. These have a high physiological trespass.
Physiological trespass. I like that term.
It means they disrupt the body so much, massive fluid shifts, huge inflammatory response, that intensive support is mandatory for the first 24 hours.
And the second factor, the patient side of the equation.
Patient factors. This is all about physiological reserve. An elderly patient with multiple comorbidities, say COPD and ischemic heart disease, who is undergoing even a moderate surgery, might need an ICU bed because they lack the reserve to cope with the stress response.
So it's not just the surgery, it's the canvas the surgery is painted on.
Perfect analogy. A healthy 20-year-old tolerates a laparotomy and goes to the ward. An 80-year-old with a poor ejection fraction might not. Same surgery, different patient, different destination.
Then we have the intraoperative factors, the things that go wrong on the table.
Exactly. Massive blood loss, say more than 1 blood volume. Prolonged surgical time, which increases cytokine load and third spacing of fluid. Severe persistent hypothermia. These patients might have been planned for the ward, but the surgery itself changed their trajectory.
What about anesthetic complications? The things we hate to see, but have to manage.
Indeed. A difficult airway where you've had multiple attempts and now there's airway edema. You might choose to keep them intubated and ventilated overnight to let that swelling settle.
A failed extubation is another classic one.
Classic admission. Residual neuromuscular blockade. If they aren't pulling adequate tidal volumes at the end of the case, they come to ICU for ventilation until the drugs wear off. And aspiration. Aspiration is another big one that requires immediate admission for observation and potential development of pneumonitis.
It's interesting how physiological reserve is the theme that just runs through all of this. A 20-year-old can handle a 4-hour surgery and go to the ward. An 80-year-old might need ICU for the very same procedure.
That is the art of anesthesia and critical care. Recognizing that biological age and physiological reserve dictate the destination more than just the name of the surgery on the consent form.
Okay, let's zoom out to special patient populations. There are a few groups that often get specific questions in the exams: obstetrics, trauma, and oncology. Let's touch on obstetrics first.
Right.
Chapter 65 is a key reference.
The pregnant patient is physiologically distinct. Everything changes. The big triggers for ICU admission here are severe preeclampsia or eclampsia. Managing the airway, blood pressure, and seizure control is incredibly high stakes because you have 2 patients to worry about, the mother and the fetus.
The HELLP syndrome is another one that always comes up.
Yes. hemolysis, elevated liver enzymes, low platelets, and of course, major expectorant hemorrhage. Disseminated intravascular coagulation, or DIC, is a very real risk there. These patients can deteriorate incredibly fast, and their reserve is often masked by the normal physiology of pregnancy until they suddenly crash.
What about trauma patients?
With trauma, you are constantly on the lookout for the triad of death.
Acidosis, hypothermia, and coagulopathy.
That's the one. If a polytrauma patient starts showing these signs, they need ICU immediately for aggressive rewarming, damage control resuscitation, and correction of clotting. Also, any head injury requiring ICP monitoring, you simply cannot manage an external ventricular drain, an EVD, on a regular ward.
And oncology patients.
Tumor lysis syndrome is the classic medical exam answer. You have a massive release of intracellular contents from chemotherapy, causing renal failure and wild electrolyte chaos. Also, specific chemotherapy complications. Ustheres mentions ifosfamide encephalopathy as a good example.
Now, here's a practical question that comes up in exams and, well, every day in real life. ICU versus HDU. Where do you draw the line? Why don't we just send everyone to the high dependency unit?
This is a common exam trap. Why not HDU, doctor? You need to be able to clearly define the different levels of care.
Okay, let's define them.
So, level 0 is the normal ward. Level 1 is the HDU. For patients who need more observation than a ward, maybe some non-invasive monitoring, oxygen therapy, or perhaps a low-dose single vasoactive drug infusion. Level 2 is your general ICU. This is where you provide mechanical ventilation, invasive monitoring like arterial lines, and renal replacement therapy. Level 3 is a tertiary ICU, which handles the most complex support like ECMO or advanced neuromonitoring.
So what is the decision matrix? How do you choose?
Simplistically, single organ failure that is relatively stable often can go to HDU. Multi-organ failure, or a single organ that is unstable, like an intubated patient, must go to ICU.
But in the real world?
In the real world, Miller correctly notes that bed shortages often force us to de-escalate care, pushing boundary patients to HDU who might be better off in ICU. But for your exam answer, you must be strict. If they need an artificial airway or high-dose vasopressors, HDU is unsafe.
We've covered the clinical decision-making, but we cannot ignore the paperwork and the talking, documentation and communication. Why is this a whole section in the exam?
Because in the modern era, if it isn't documented, it didn't happen. Medico-legally, you must document a clear indication. Observation is not a diagnosis. Why are you observing? Risk of airway compromise post-thyroidectomy is a valid indication. Just in case is not.
And communication with the family.
Absolutely crucial. Managing expectations from the very beginning. If you are admitting a priority 3 patient with a limited prognosis, you must document that you have discussed the limits of care with the family. Are we doing CPR? Are we dialyzing? This prevents ethical disasters down the line.
Let's talk about exam traps. In Aviva, the examiner is often trying to lead you down a garden path to see if you'll walk into a hole. What are the common pits to avoid?
Okay, prep number 1. Admitting a palliative patient. The examiner says, this patient has end-stage lung cancer and is gasping. Do you admit them to your ICU?
And the knee-jerk answer is no.
But that's too simple. Your answer isn't a flat no, it's nuanced. You say you would admit if there is a clearly reversible component that can be treated quickly, like a simple pneumonia, or for specific symptom control if specialized interventions are needed. But you must mention they are priority 4, and you would strongly consider a time-limited trial.
Explain time-limited trials. That's a great phrase.
It's an agreement you make upfront. You say, we will admit for, say, 48 hours of intensive therapy. If they show clear signs of improvement, we will continue. If they do not, we will transition to comfort care. It shows you are ethical, but also realistic. It balances hope with futility.
Great answer. What's another trap?
Admitting for nursing care. The examiner says, Doctor, the ward nurses can't handle this patient's frequent suctioning schedule. Do you admit?
The trap is to say that's not an ICU indication.
The trap is to say that. The correct answer is, if the nursing ratio required, like 1-to-1 care, is only available in the ICU, then it is an indication for admission. Patient safety trumps geography. If the patient will aspirate and die on the ward because the nurse has 10 other patients, you admit them. It's a nursing needs-based admission.
And the one-number trap.
Never rely on a single abnormal lab value. The examiner says the lactate is 4. Okay, but is it coming down from 8? Is the patient sitting up and chatting on his phone? You must emphasize trends and the total clinical picture over isolated numbers. An isolated number treats the chart, the trend treats the patient.
Okay, we are in the final stretch. The student is sitting in the exam hall pen in hand. How do they physically structure this long answer? Give us the model answer template.
Visuals are key. Examiners are tired. They are reading hundreds of papers. Make yours easy to read and easy to grade.
Step 1.
1. Introduction. A short paragraph. Define the ICU using the O's definition we started with and state the objectives of admission.
2.
2. The table. Immediately draw the priority 1 through 4 table. List the priority, the definition, and an example for each. It takes up space, it looks professional, and it shows you know the guidelines cold.
3.
3. Flowchart. If you have time, sketch a simple triage algorithm, a box that says critically ill patient with arrows to stable versus unstable, leading to reversible versus irreversible. Did a great visual aid. 4.
4. Headings. Use the system-wise headings we discussed. Respiratory, cardiovascular, neurological, renal, sepsis. Don't write big blocks of text. Use bullet points under these headings with the specific numbers.
And the conclusion.
5. Conclusion. Summarize with the safety aspect. It is always better to err on the side of caution. It is better to admit and then downgrade the next day than to miss a sick patient who arrests on the ward.
That is a solid, foolproof framework. It covers the theory, the guidelines, the clinical detail, and the safety net.
It's how you get the marks.
Before we sign off, let's do a rapid-fire summary recap for the drive home. The absolute must-know points.
Right. Let's do it.
Reversibility is the golden rule. No reversibility, no ICU bed. 2. Know the priority model. Priority 1 is unstable and needs everything. Priority 3 has limitations. You must know the difference.
3.
3. Numbers matter for the exam. Urea greater than 35, respiratory rate over 35, GCS less than 8. Quote them.
4. Post-op admission is a function of both the surgery and the patient's physiological reserve. It's never just one or the other.
And 5.
And 5. Documentation protects you and the patient. Discuss and document the limits of care early.
Perfect. And to leave our listeners with a final provocative thought, something to chew on for their next Viva.
Here's something to ponder for the advanced student. With the rise of ICU outreach teams and rapid response systems, which Oz discusses extensively, are traditional admission criteria becoming obsolete?
How so? That's a bold statement.
Well, as we bring ICU skills like high-flow nasal oxygen, complex vasoactive infusions, even non-invasive ventilation onto the ward via these rapid response teams, the physical walls of the ICU are becoming more porous.
Interesting.
So we need to ask, does the patient need the place, which is the ICU bed, or just the skill, which is the intensivist and the critical care nurse? If we can deliver the skills safely on the ward, maybe the criteria for needing that specific geographic location will change drastically in the next decade.
That is a fantastic point. The ICU is becoming a concept, a set of skills, not just a room with a ventilator.
Exactly. Something to think about.
Well, to all our listeners preparing for the MD anesthesiology exams, good luck. Review those numbers, practice drawing that table, go crush that paper.
You have got this.
See you on the next deep dive.